it become all small, little window on the right side. It's crazy.
Yeah, I think you, as Dr. Donald said, yeah, you probably, if not, you have to like switch the screens. Maybe you're in the mirror screen on the other side. So just, you have a Mac, right?
I have a Mac. That's the problem.
Just 3 fingers, just swipe to the other screen. Yeah, I think as Dr. Donald said, yeah. Probably, if not, you have to like switch the screens. Maybe you're in the.
Can you see Marco or no?
No, I'm having trouble. So let's see what's going on here now. Hello?
Yeah, yes, we can hear you.
Okay, perfect. Now yes, great. Ok, I'm here. Good. No, un'altra è la salsa di pomodoro, come la fai?
Salsa di pomodoro, sì. Prendo una latina di San Marzano tomatoes per un drenaggio nella rete per un'ora e dopo questo un po' di sale, come si dice, un pezzo di garlic, un
pezzo di aglio.
Taglio di garlic e basta, un po' di qualche volta un po' di zucchero, non mi piace zucchero nel tomato, per me non va bene, ma qualche volta un po' di zucchero e per tu come fa? Basilico, sì, basilico e oregano sulla pizza,
Hey guys, do not copy our recipe. This is like a trademark. All
yeah.
Done here.
But I need a true pizza oven. I cannot get the crust right without the high temperature. It's very difficult, very difficult. I have stones, I have this, I have that, but you need the high temperature.
Yes, that's true. That's the secret also. And the range, at least 24 hours. So,
by the way, Dr. Rajhi is very interested in also saying hi. He's about to log in before we start.
Perfect. Yes. Dr. Rajhi is our CEO of the hospital.
Oh, great.
Abdulaziz, is he there, Adel?
Please, let him feel free to make some comments if he wishes.
Maybe he could talk some Italian with you guys, because
is Dr. Abdulaziz there or not, or at the end?
I think he wanted to, he has a meeting later, so he just wanted to say hi for
okay, wait, he's not here. Okay, let him in. I don't know how to do it.
Yeah, he's logging in right now, but we could just wait for him. Just a minute.
CEO, Dr. Rajhi, speaks Italian very well, Don.
Are you serious?
Yeah. He lived in Rome many years when he was a kid.
Everybody speaks Italian, and I'm the guy who got stuck learning it as an adult. You know, when I'm born again, I'm going to be born in Sicily this time. I will, but then I'll speak Sicilian dialect, and you won't understand.
Exactly.
So I remember you've shown in one of your presentations the time of year where in New York the sun lies
yes
and like in the streets.
It's called Manhattan Henge. It happens twice a year when the sun perfectly sets in line with the horizontal streets, and it's like setting at Stonehenge, and we all go out and celebrate in the streets. It's a very interesting day, twice a year.
From north to south, basically, right? I mean,
yeah, from east to west.
Okay.
Yeah, I'll send you that picture, Adele. If you send me your email, I'll send you that photo.
I loved it. It was very the part you talked about your experience in the OR was very emotional. So it stuck in my head since then.
Unfortunately, I'm always very emotional. That's
that's part of being Italian, I assume.
Don, Dr. Rajhi is online.
Buongiorno, Dr. Rajhi.
Buongiorno, signor Dr. Don, come stai?
Tutto a posto. Ho sentito che parla italiano perfettamente, sì?
Beh, cerco di farlo, insomma, non è bene, ma cerco il meglio. Come sta?
Sì, la situazione in New York sta migliorando ogni giorno. Va. Sì, but
Mi fa piacere, mi fa piacere.
It's
Spero che
wonderful.
lo stesso succede qui a Riyadh.
Wow, it's fantastic. It's such a pleasure, and thank you so much for having me on. I am very much an enthusiast for Dr. Moura. I think he's one of the greatest vitreoretinal surgeons in the world, and I'm honored that you guys have me on to give this lecture. So thank you again.
It's our pleasure to have you, and thank you very much for accepting our invitation. And I echo your sentiments. Dr. Marco is a pillar now at KKH, and he is driving the development and advances in ophthalmology within the hospital and the department. I know that you have a very busy schedule, and we are very grateful that you took some time to be with us, and we all look forward to your presentation.
And I look forward to meeting you at some point in person and learning the subjunctive from you, because it still makes it still difficult for me.
Well, my Italian is not as it used to be, but you know, I try to practice as much as I can, especially when Marco and Diego, our two colleagues at the hospital, are around. But you know, we try to struggle. It's not easy.
Very good. All right. Well, thank you. And I'm ready whenever you guys decide it's time.
Yes.
Perfect. Looking forward to it.
Don, I think everybody, we should start because this time. I have a microphone. Somebody has the microphone open on the background, and it's very noisy.
I think it's better now.
Okay, great. So, good afternoon, everybody, and welcome to the Global Education Forum. Today, we have Professor Donald D'Amico with us. Don is a very good friend of mine, and it doesn't really need introduction. It's a worldwide famous ophthalmologist and retina specialist. He's a professor of ophthalmology and chairman of the Weill Cornell Medical College in New York. He's the ophthalmologist in chief of the Presbyterian Hospital. And he made many achievements in his career, and we are really honored that he took time to stay with us and enlighten us about permanent keratoprosthesis, which he will try to make us believe that is an opportunity for the vitreretinal surgeon. So thank you, Don.
Thank you, Marco. Again, a great honor and pleasure to be with you and with all of your guests at the King Khaled Eye Specialist Hospital. You have really done an amazing job with making it a leader in vitreoretinal surgery, and I continue to be impressed by your educational programs as well. This day, I would like to make some remarks regarding a complicated subject, one that some ophthalmologists feel is almost hopeless, and other ophthalmologists feel is full of opportunities. And of course, I'm speaking of permanent keratoprosthesis. This has been a lifelong passion of mine to work with anterior segment surgeons on this, and today I will share my broad experience in terms of the years, the mistakes, the things I've learned, the new discoveries, and then we'll certainly reserve plenty of time for your questions at the end. So here we go. My only disclosures are that I am a consultant for Alcon, and I will mention the use of intravitreal triamcinolone and intravitreal dexamethasone implant, or Ozurdex, in this talk. To begin, I simply have to thank and honor Dr. Klaus Dohlman, who was my first mentor as an ophthalmology resident. He had a dream as a very young ophthalmologist to develop a permanent keratoprosthesis. But when he was doing this way back in the probably the 70s or maybe even the 60s as a young student, he realized that the techniques were not available to obtain good results. And he said, this is a project for an older man. This is a project for someone who has established their career, maybe is looking for something to do meaningful in near retirement, because the results will be so slow to develop, and it will be so difficult You can't be distracted. And to his amazing credit, he did that. After he retired as chair at Harvard, he went back into the laboratory, developed the keratoprosthesis, even though many of us call it the Boston keratoprosthesis. I will forever refer to it as the Dohlman keratoprosthesis. At that time, I was a younger retina specialist at Mass Eye and Ear, and he was doing these cases. And I don't know, maybe I was just happened to be in my clinic one day and he brought up the first complicated patient after surgery. And that began a many-year relationship where we shared the toughest cases together. And I learned so much, not just about K-Pro, but also about ophthalmology from this remarkable man. I want you to know that he is still going strong. He is in his 90s. He still drives independently. We see each other when we could pre-COVID at dinners, and he's a remarkable figure. The second person that I wish to acknowledge is my own wife, Kim Sipple. Kimberly is a cornea fellow trained by Dr. Dohlman and is an expert in keratoprosthesis. And I hate to say it, but we operate together. Now, I have to tell you that operating with your spouse is not for the faint-hearted, and I'm not even sure I would recommend it. But we've learned to do it and do it well, and we are completely different in the operating room. We always decide in advance what the stopping points will be, who's in charge of what, and we've developed some curious habits, which I'll share with you as we go forward. So I'm really lucky that I have both Kim and Klaus to draw on, as well as many other corneal surgeons in our group. And in fact, New York Presbyterian Weill Cornell has become a national center for permanent keratoprosthesis. Here is the Dohlman keratoprosthesis. As you know, it comes in two types. Type 1, which is strictly intracorneal, is by far the most common. Type 2 is quite rare. It has an extra piece that allows you to close the lids over the cornea. This is used in cases with severe ocular surface disease. But I have to tell you that we rarely use the type 2 device. I don't think we've used it in 5 years here at Weill Cornell because new drug treatments and other modifications allow us to use the type 1 device more successfully. As you know, the device has a 3-part structure. There is a front plate, and then there is a back plate, and then there is a piece of donor cornea, which goes in the middle, which allows suturing of the device to the cornea. There have been many other devices. This is conceptually a very simple surgery in the mind. You know, just take out the diseased cornea and put in a piece of plastic. That is until you try to do it. And you can see just a list of 7. 4 of them are really no longer used in the United States at all. The worst, the Fyodorov, Zuev, the Moscow eye microsurgery, and the Leger. In addition to the Dohlman prosthesis, there's the osteoodonto, which is an amazing device developed by Cardona and others, in which a piece of tooth is implanted somewhere in the body, usually in the hip or the abdomen, abdominal skin, and allowed to cure for several weeks, and then harvested, drilled, and used as a cornea. And then there was a device, I believe from Australia, the Alpha Core, which had a titanium mesh design. These unfortunately were complicated by high rates of extrusion. So we use exclusively the Dohlman prosthesis. The osteoodonto works very, very well, but it's such a complex surgery that usually everyone that's done a few a year winds up being presented on television. And here again is the structure of the Dohlman prosthesis. I regard the fact that we still need to use a piece of natural cornea as a drawback. And unfortunately, we have no substitute as yet, but it would be wonderful if we could someday develop a fully synthetic device. It would allow shelf storage, use in places where corneal tissue is not readily available, etc. One piece that was added several years ago is a locking ring on the back of the stem. So you push the stem through the piece of donor cornea, through the back plate, and then you have a locking ring that secures it. Well, why is the locking ring there? Well, it's there because an early model had a screw design, and one of the fellows was cleaning the device at the slit lamp and accidentally unscrewed it from the eye. So there's a locking ring in place that secures the sandwich construction and allows it to be secure. On the lower right, you also see a titanium back plate. This was developed by Jim Chodosh and others in association with Dr. Dohlman at Harvard. And the idea was that maybe titanium would produce a lower incidence of retro-K-pro membrane. It really hasn't worked out that way. And although the titanium can be dyed to make it look not so robot-like and objectionable, it hasn't become a popular design, and we typically still use the plastic backplate. Why would someone need a permanent K-pro? Well, probably the most common indication is multiple failed corneal transplants. As you know, if your first transplant fails, the odds of your second, third, and fourth failing go up exponentially. And there have been trials that show that even one failed corneal transplant, you may be better off with a K-pro for your second procedure rather than a second biological transplant. A second big group are patients with chemical burns. The ocular surface is so altered in these patients that sustaining a biological cornea is not possible. Stevens-Johnson syndrome is incredibly difficult, and as you know, it not only damages the surface but damages the lids and creates synechiae and symblepharon, etc. The surfaces are incredibly dry, and you'll never get a biological cornea, but with some tricks you can get a K-pro to survive. And then the other indications are also used. Patients with chronic hypotony, cicatricial pemphigoid, uveitis, some cases of trauma, severe atopy, aniridia, and graft versus host disease. These are all cases in which a biological cornea has essentially no chance, and which you may have a fighting chance with a permanent keratoprosthesis. People say, well, we do these, and I saw a case and it was bad. And I understand that early on, visual results were disappointing, but here's a number of series that show really impressive visual results. And you can see then in the second column, the typical preoperative visual acuity, and look at the number of eyes: 300 eyes, 75 eyes, 44 eyes, with postoperative acuities that are quite in the useful range and sustained for many, many months. So this is a path for visual restoration for many patients. And considering that many of these patients are uniocular, this is salvation for them. How does one evaluate whether a patient is suitable for a keratoprosthesis? Well, obviously, by the time they arrive at this point, there have been multiple surgeries performed, multiple doctors, discouragement, injury, loads of medications. So begin with a very careful review of the ocular history and examine the eye as best you can for the state of the surface and the cornea, whether there's glaucoma present, and frequently there is. We'll talk about that in a moment. And get what information you can about the retina. We'll do an ultrasound with care to image the optic nerve head. And occasionally we'll find a completely cupped out optic nerve head, which will tell us do not proceed with surgery. You have to counsel the patients that lifelong care will be needed. Even if the operation is a failure, you'll have a prosthesis at the border between the body and the outside world, and it will require antibiosis and other care. So this can be a commitment that some patients are unable or unwilling to take on. Occasionally, we'll do this and the history is incomplete and we really don't know. We will do an exploratory endoscopy in order to see whether we should proceed with a major surgery with a K-Pro implantation. Typically, and I'll show an example in a second, typically I do this as a separate surgery. So I don't even commit to going forward at the same surgery if I can help it. I will say, listen, it's such a complicated undertaking. We're going to do a 30-minute procedure in 3 days to see whether we want to bring you back in 2 weeks to do the whole double team surgery. And here's an example. I'll get to that in a few more slides. One other thing to know about K-Pro is that when you're struggling to look in, your wide field cameras give you a superb view. So the Optos camera in particular gives an absolutely fantastic view. And I tell the members of our cornea service, don't even try with the indirect ophthalmoscope unless you're a pro. Just get an Optos of the patient. And you can see here beautiful wide field images of the retina through the device, as well as excellent OCT. Recently, we've noted an interesting tendency in these devices to better biointegrate. What do I mean by that? Well, if you look carefully at the big image on the left, you can see, except for the very central space, the epithelium, the corneal epithelium, is crawling over the device, over the host interface, and attempting to biointegrate. We never saw this in the early years, and we've done studies showing that this is in fact corneal epithelium. Occasionally it can even be a little bit of a problem. There, every few months you may have to brush it back with a cotton tip to keep the interface clear. But we're optimistic that as the surface management improves, we may obtain a better biological seal for this device and reduce our need for topical antibiotics and greatly reduce the small risk of infection and extrusion. So just be aware that we're seeing better biointegration in the device in the current era. We also will look with anterior segment OCT, and we can occasionally find things such as areas where the device may have a gap between the host plastic interface. You can see this very nicely in Dr. Alzaga's publication with us. Even a little cyst has formed at the area. We're studying this because obviously the ability to have the device integrate well with the body is critical for any prosthesis. With regard to visualization at vitrectomy, in older days, I would use the AVI lenses, which you can see give superb visualization, but now we typically use the Zeiss Resight device, which also gives superb visualization. You can use a conventional flat contact lens, but I think you'll be much happier with wide field viewing, and it works very, very well. Here's that endoscopy. It's a little hard to see, but this is a patient who we didn't know if had a useful eye at all, vitreous hemorrhage, one-eyed elderly man. And by the time we cleared out some of the material on this slide, if you look very carefully on the right, you can see the optic nerve. In the center, we could see the macula was attached. And although the macula had some atrophic changes by visualization, the optic nerve looked pretty good. The macula and retina were attached, and we said, let's go for it. And this patient recovered 2200 vision, which was a great help to him since he was previously blind. Beyond my ability to do a diagnostic endoscopy, I am not so skilled with the instruments such as people like Claude Boucher of France and others who are masters at this technique. So I am not able to actually do much more than diagnosis, but I think it's a tool that can be very helpful if you're deciding whether or not to proceed with surgery. One of our preferences we're known for is we do a full vitrectomy at the time of all K-Pro implantations if possible. So we feel that the vitreous can only hurt you, and we also prefer to do aphakic or K-Pros over pseudophakic K-Pros. Let me say a word about that. If you talk to corneal surgeons and an eye is pseudophakic, they love leaving the IOL alone. They say, oh, I have the lens iris diaphragm. I don't have to touch anything. I'll be protected. And they then put a transplant or a device on top of the eye. I hate it. I think that IOL usually has a residual capsule and inflammation and cellular material. And plus, if you get a retro K-Pro membrane, it's really difficult to operate between the back of the K-Pro and the front of an IOL. I've even had to couch some of these IOLs in the past. So I prefer to remove the lens and capsule and IOL completely, remove the vitreous gel, and work in that kind of eye. We now use 25 gauge for all of these. And where do you go in? Well, if you know that the back plate is approximately 7.5 millimeters in diameter, that means for safety, you should really enter 4.5 millimeters from the center of the device. If you think the anterior segment was relatively normal, you can go as far as 7 millimeters from the center of the device. But remember, many of these eyes have foreshortened anterior segments, previous difficult surgery, hypotony, and your concern is just getting outside the back plate if you're doing entry into a device with a K-Pro. One other thing that I will mention that I regard as mandatory is if you are doing the primary implantation, and of course you've put your cannula on and your vitrectomy ports first, if you can, that once the damaged cornea comes off and you have that moment where the eye is open sky, take a brief look at the posterior segment. Don't immediately put the K-Pro on. Here's an example of that. This eye is opened. I just put the light pipe on top of the vitreous lake. I can see, yes, the retina is attached. The optic nerve has atrophic changes, but we know the patient had ability to detect count fingers vision earlier, and now cover the eye with the K-Pro. The reason I say this, and I've actually written an editorial in Retina about this, is that too many surgeons, corneal surgeons, will immediately put the K-Pro, and then the first post-op morning, there may be some haze and they're struggling to get a view. What would the back of the eye look like? And they're struggling with ultrasound. Don't pass up the chance when you have a clear view in the operating room to take a look at the back of the eye. What are the complications that can occur? Well, there are many. And if you like complications, welcome to K-Pro surgery. They can be present before the implantation. They can happen during the surgery of implantation or develop following surgery. The big one is glaucoma with optic disc cupping. These patients have been through many difficult situations, and unfortunately, many present with glaucoma. Chemical injuries, as you know, predispose to glaucoma, so the severe anterior segment burns often will have damage. That's why it's important to get to them early. Macular atrophy, hypotony, and retinal detachment are things that can present, and we'll show examples. During the surgery, you can have vitreous and suprachoroidal hemorrhage, and watching the retinal contents be expulsed through the open eye is something that you'll never forget. Vitreous hemorrhage, if you keep the cannula on with an occasional low flow up through the open eye while the device is being placed, you can keep the vitreous cavity clear. Intraoperative retinal detachment is rare, but it can occur. And then post-op complications we'll discuss right here. The number one complication is the formation of a membrane on the back of the device. And this happens in almost half of devices. Usually it can be removed successfully, but it will recur in many. And I've tried a number of things to reduce the occurrence, and we'll speak briefly in a moment. Sterile inflammation, surprisingly, when you see a device that has a lot of cells in the vitreous behind it, say 2 months or 4 months after implantation, it's most often sterile. And that was surprising to us, but the device can produce inflammation. Of course, detachment, pucker, hypotony, vitreous hemorrhage, and suprachoroidal hemorrhage can all occur post-op, and we've written articles about it, as you see here. Now, here's a retro-keratoprosthesis membrane. This was done 23 some years ago. I typically go in with a blade or needle. I barb the end and just hook it off. And once I have some openings in it and good edges, I'll then use the vitrector and clean it. You can even use forceps, and sometimes these can be very tough, but this is a wonderful surgery and can bring patients back to great visual acuity. If it's early, you can also do a YAG laser as an outpatient, but plan to use more energy and plan to do it only if the membrane is earlier. Here's an example of a complicated eye where the IOL had to be removed. We made a larger incision. You can see this patient's had many incisions, this one-eyed patient. This is something that I'll show cleaning off the device. I've wanted to do this to the cornea for a long time, scrub the back of it, and now I can finally do it. And so we removed the intraocular lens here and then resecured the device. So that can be done. Here's an example of sterile inflammation. You'd think this eye has endophthalmitis, but actually all of this is just sterile debris. And when we removed it and treated with topical steroids, vision was returned and the eye remained quite clear. As you can see, the retina looks great apart from some optic disc cupping. Now, this is true endophthalmitis. It wouldn't surprise you at all. This was a fungal endophthalmitis in a patient who was sent to us with fungal endophthalmitis. And I tried to remove the material, but I have to say that during surgery, I ultimately gave up when I saw how necrotic the retina was. But cases of endophthalmitis do occur. Fungal is rare, but certainly lifelong prophylaxis is required. Now, this is an interesting case. This is a patient who had a retinal detachment with failure of the cornea subsequently. So he was sent to us with PVR, with lens material left in the eye. So we first had to implant a keratoprosthesis, which then brought us to the point of doing a PVR surgery. You can see we have superb visualization. It was subretinal PVR primarily. He had also had subretinal hemorrhage from his many previous surgeries, but this behaved much as you would all do in a subretinal PVR surgery in an otherwise normal eye. He did have the additional complication of the K-Pro and also had some pre-existing suprachoroidal hemorrhage, but we were able to secure reattachment and a clear view. And in a bit, I'll show you his post-operative appearance. He returned to 2300 acuity and was thrilled. Unfortunately, he developed a retro-keratoprosthetic membrane. And although we know we could restore his 2300 acuity, he's quite elderly and has reasonable vision in his other eye. And we've chosen not to do additional surgery, keeping this eye as a backup. Now, here's a very unusual patient. This patient had previous corneal surgery, previous keratoprosthesis, retinal detachment, trauma, and we found a DSEC button in the back of the eye, which was unknown. And I'm very pleased to say that our 25 gauge vitrector or 23 gauge, whatever it was, can eat this very nicely. So if you encounter a DSEC button, then we found glass, multiple glass fragments that had not been removed in any of his prior trauma surgeries. And we removed many. They looked like pieces of diamond. And you know, there were many, many fragments that had to be removed. So we've taken a desec button out. We're removing glass before we get to the PVR repair. And in this patient, we used gas. We were able to intraoperatively reattach the retina, remove membranes and all of that. But here he is on the first day post-op. It looks great. However, over the next 3 weeks, he developed a horribly complex subretinal, preretinal contracted PVR. And I was shocked by this. I think it was probably from all the additional micro trauma to the retina from the glass fragments. But given that he had a normal other eye, I suggested no further surgery, and we did not. Things like macular pucker you can manage with good visualization, just as you would in a normal eye. While you're there, if there's any retro-K-pro membrane, you can clean it off. But here's a typical case of pucker. And it's something that if it occurs, we have no difficulty in performing surgery for such patients. Choroidal detachment and hypotony post-K-pro. Originally, we had so much problem, Dr. Dohlman and I, with glaucoma that we went through this period where we were implanting a valve in every K-pro eye. And that worked for a while until it didn't. And here's a patient in which it didn't. A young man with congenital aniridia and problems in both eyes had great visual results, but I suddenly got a call that he was losing vision. And we saw that he started to have choroidal detachment, and we were terrified about hypotony and ptysis. And here he is now with, you know, bare light perception vision, and we're terrified. He had been, you know, back at school seeing well, and we realized that he had an active valve that was perhaps over filtering. And so we went in and tied off and ablated the valve, closed the tube, and he began pumping back up and completely reinflated his eye with return of vision. Since that time, except in the most severe glaucomatous eyes, I prefer no tube, because we're now having more problems because of the tube than of the absence of tube. And I'll take my chances with glaucoma and giving drops and, you know, Diamox and all of that, but I just have had some bad experiences with the tube. Nevertheless, if you see hypotony develop post-op, consider tying off the tube and see how that will work for you. How do we do with these complications? Well, retro-K-pro membrane, about half of the eyes, as I mentioned. Sterile inflammation is rare. Detachment is somewhere between 2 to 20%. Pucker is also rare, and the others are quite rare. And we've reviewed our experience, as have others. So complications apart from K-pro membrane are fairly rare. Now, this is an unusual one. This is a patient with a retro-K-pro membrane sent to me by Klaus in the early days with a type 2. I couldn't even find the eye. So I decided to do a TransLid K-pro membrane removal. I did a vitrectomy TransLid. I didn't see the sclera. I didn't close anything in the sclera. All I did was make incisions in the skin across into the eye, find my way with the instruments and remove the K-pro membrane. And this patient and several others have done extremely well. I hope I am never sent another patient where I can't even find the eye. This patient was so unusual. I believe it was published on the cover of the then Archives of Ophthalmology. Profound hypotony and what we used to call ptysis is an opportunity for us. We have many eyes in our clinic that are pressure of 0, cloudy cornea, but yet we call them ptysical, but we don't really understand, could there be any vision? Well, here's a patient from West Africa, an executive who was in a bomb explosion, who had profoundly shrunken, damaged eyes. But Dr. Dohlman said, why don't we try and see if we can salvage some vision in this patient? So we implanted a K-pro in this gentleman, and he retained 20/60 vision for more than 3 years, at which point I lost his follow-up. What does this tell us? It tells us that some eyes that would be forced to have a cloudy cornea and therefore no vision with biological corneas may have visual salvation with a K-Pro. And again, this patient, I believe, was on the cover of the Archives of Ophthalmology. Some patients we just can't help. Here's another bomb blast from a patient who had presented to us with a retinal detachment where the one eye was no light perception, the right eye had light perception, but if you look, the retina is detached so badly that it's actually stuck to the back of his prior K-Pro implantation. I tried my best. I was able to put some fragments of retina back, as you see in the right, through a very hazy photo, but unfortunately his vision remained bare light perception. Finally, I'll show you what I think may be one of the more remarkable patients in my career. This is a gentleman who was blinded by Stevens-Johnson syndrome bilaterally at age 12. He had no vision for over 30 years. So this gentleman grew up as a blind person. You see the right and the left eye. My spouse, Dr. Kimberly Sipple, said, would you be willing, we think the surface is quiet enough after 30 years, we could try a K-Pro implantation. So typically, I know this will sound crazy, but I usually do the exploratory part, having learned. So unfortunately, criticize as you will, this is me. I'm the guy who tries to find the eye, having been trained by Klaus to do this. We're opening the synechia between the lids, and then the multiple layers of membranes that you'll see in order to find the cornea. And then here I am, exposing now closer to the surface of the globe. And now it begins to look a little bit like an eye, but still there's strong pannus over the cornea. And I use sharp scissors for this, and we dissect and then, cut this off until finally we get something that looks like it once was a cornea. And then at this point, I also like to do the trephination, but as I've mentioned, of course, I have the cannula on. We determine where our K-Pro will go and do our trephination, and then carefully remove the lens, in this case by intracapsular extraction, removing residual capsular membranes, implanting our device. We're planning to do a full PPV here. And here's the device in place. And then we do the vitrectomy, and the posterior segment was completely normal. And at this point in the operating room, the staff and technicians and other surgeons are jumping up and down, and we were very, very hopeful. I usually don't suture, I just compress the wounds and try it in that way. And so that was his surgery 32 years after being bilaterally blinded by Stevens-Johnson syndrome. To our amazement, the next morning he was 20/70 and maintained that visual acuity for a year and a half, which, as you can imagine, was transformative for this individual. We have not attempted surgery on his second eye. He has subsequently had difficulty with the vision in this eye due to an infection that he developed and neglected, but we are considering doing a similar surgery at some point in the future when he can be better followed due to his social circumstances. So at that point, I would just like to conclude with two things. Number one, thanking the many people who have shared their innovation, their efforts, their work, their patience, their ideas, and also to the K-Kesh Hospital for giving me this opportunity to share some of the most interesting to me surgeries of my career. I think that K-Pro will continue to develop and continue to be a pathway for better vision for many otherwise hopeless patients. And at this point, I'd like to go back to Adele and offer it to any questions. I will stop sharing my screen now if I can figure out how to do that. So stop share. So there we go.
Bravo, Don. Very nice. Very nice. I really loved your videos. Great. I mean, I never did a vitrectomy TransLid. I mean, this. Are there some questions? Otherwise, I can make some at the beginning.
You can start, and I'll start after.
Don, you show beautiful surgeries. I mean, and you mentioned the problems with the K-Pro. Of course, it's not a surgical procedure which is free of complications. And you show very nicely some of them. I mean, how are you sure it's the sterile or not? Or you treat them all as a normal endophthalmitis? You always do tap and inject, or you have some tips to tell us how to recognize a sterile endophthalmitis from a real one?
Yeah, so there's actually Marlene Durand and Klaus Dohlman wrote a very nice article. If the patient can be well followed, and if it is a situation where there is no involvement of the host corneal rim tissue and it's strictly intraocular material, I will try in many cases for a day with heavy steroid topically. So topical Durezol, maybe even some oral prednisone. And you'll know quickly, if you suddenly see the inflammation reduced by half, then you don't have to do a tap and inject. I know this is contrary to my usual advice. You can slap me if I am making a heresy here, but I think you can, in these patients, do a quick trial of high dose steroid. If it's the same or any thought of progression, then do a tap.
So, and basically 24 hours, that's what you do?
Yes.
24 hours, okay, great. You spoke also about the valves. Basically, you don't put any, because here in KCash, when we do it, we tend to suggest to put a valve in advance. So you don't do it anymore.
Well, we do a few, but it's by no means the majority anymore. And the issue is that many of these eyes are so damaged anyway that I'm not sure that the valve is really helping preserve the visual acuity. The valve is a pathway for hypotony, and we see a number of eyes referred to us for hypotony. So probably, Marco, in 2 years, I'll be telling you, put a valve in every case. I'll be running away from the new problems that I'm having. But for right now, if there's no evidence that there's severe glaucoma and the patient can be well followed, I probably would avoid a valve, at least initially. I think I dislike inflammation. And I think the valve contributes to inflammation, which may contribute to retro-K-Pro membrane and other problems. So that's my rationale. But my thinking is not perfect or complete.
Good. I think Dr. Raji wants to ask a question. I see him in the back.
Oh, yes.
Can you open it? He's muted.
He's muted, Adele.
Yeah.
Okay. Am I fine? Okay. Do you hear me now?
Yes.
Okay. I was saying it's a great presentation. Thank you very much. Beautiful videos, beautiful cases, and we've all learned a lot from it. Several years ago, a long time ago, actually, we had a visitor at KKH, Stefano Pentucci, where he presented the Pentucci-Keratoprosthesis. And at that time, and as you know, it has a dacron felt around the main cylinder, which he claimed at that time that it provides better adhesion to the corneal tissue and less chances of inflammation, rejection, and infections, or exclusion of the prosthesis. And it looked quite successful. And I actually went to Rome and stayed with him for a month and saw his cases, and he had really very good results. And at that time, he used to remove the whole iris. He just detaches and removes the whole iris from the eye in order to prevent any possible cases of glaucoma. Now, he passed away, unfortunately, a few years ago. And I don't think there are many people that still do the Pentucci-Keratoprosthesis, except I think in India, there's a center in India that does it, and a few other scattered places. Do you have any opinion on the Pentucci-Keratoprosthesis?
I'm familiar with it. I have no personal experience. I must say that the idea of removing the iris as a method of glaucoma control is one that I have not explored, but I'm very interested in. And I had years ago a conversation with Mario Stirpe, who told me that in cases of profound neovascular glaucoma, avulsion of the iris had produced at least temporary reduction in pressure. But I think the idea of a better biointegration, such as Dr. Pentucci was working on, would be a help. I do have to mention that our problems are not really extrusion anymore. It's very rare for us to have a keratoprosthesis that extrudes, but our problems are more inflammatory issues in the eye that result in retro-K-pro membrane. And I've tried putting intravitreal steroid, intravitreal Ozurdex in the eye in order to cut down on that. And people have even talked about anti-metabolites. But I would love to have more experience with the Pentucci keratoprosthesis. I don't believe it's approved for use in the United States. So I will also have to go to Rome for 1 month like you. And I want to know more of what you enjoyed in Rome for 1 month.
There are lots of things apart from the keratoprosthesis. Thank you very much.
Thank you.
So,
good questions, Adel.
Yeah, some questions. Yes. So questions about have you done any cases under local anesthesia if it was not possible to do it under general anesthesia, and you think that it's a safe procedure to, I mean, like a vitrectomy and Posterior?
Wonderful question. Yes, I have, and I will tell you what the modification is of surgery. You know, when you do a corneal transplant, you have to verify that you have tissue and all of that. And so what we used to do was I would expose the eye and trephinate, and then we would go and assemble the device. But if we have a patient where we're sure everything is all lined up, Dr. Kim, my spouse, and her team will in parallel begin assembling the device. I will trephinate and open and then take my quick look if I'm not doing a vitrectomy, but usually I am. And so immediately the device is put on, and we've done many under local anesthesia, MAC anesthesia. It works very well. Our times are for the full surgery, not much more than an hour now, so I don't know how to compare with times, but we're pretty fast at it. Much depends on the complexity of the initial dissection. Obviously the Stevens-Johnson patient took some time, but if it's straightforward, you can easily use local.
A question from our chairman of the anterior segment division, Dr. Jose Vargas. He's praising your presentation, and he has a question about have you had to perform a PVV cases where a 9.5 millimeter posterior back plate was implanted?
Yes, I don't like the big back plate. I think it has no use, and I always use the smaller back plate if possible. I'll tell you a story. Tell me his name again. I couldn't hear you, were muted.
Jose Vargas.
Jose Vargas. Dr. Vargas, I had one patient who had an incredibly calcified host cornea. And so we got a bed opened, and then we realized we had only the larger back plate in the package. And so how do you make a larger, and it wouldn't fit. It literally would not go across the corneal opening. So what I did was I took a Petri dish, a plastic Petri dish, and I covered sterilely the device. And then I took 2 forceps and I was cracking the wings off the back of the device. And every time I would crack one, the device would jump like a bug up to the top of the Petri dish. And we were terrified it was going to become contaminated. So from that moment on, I've never seen any use for the larger back plate. And, I tease them in Boston. I say, I always want the smaller back plate. Do you have an opinion yourself, or is he able to offer me some information? Does he prefer the larger device?
Dr. Vargas, you can, I'll allow you to talk if you want to share your experience.
Okay, can you hear me now?
Yes.
Thank you so much for such a beautiful presentation. I really enjoyed it. It's a very informative and beautiful videos. My experience is with 8.5 millimeters back plate and 7 millimeters back plates. But there are 2 in series, one by Dr. Colby, and the other one is by Dr. Juan Carlos Abad from Colombia, where they implanted a 9.5 millimeters posterior backplate, looking for a decrease in an RPM. Why? Because we know that the better the apposition between the receptor and the host, the less possibility for us to have an RPM. They found that it was equal, the percentage of RPM, but incredibly, they found an increase in the possibility for retinal detachment. 22% of the cases had retinal detachment. And the reason for that is because this backplate produced more inflammation, and besides that, for some reason, increased the possibility of PBR in the retina. And this increased the possibility for a retinal detachment.
Well, you are speaking music to my ears, because I fight constantly, not with you, but with my anterior segment colleagues here, and they're always suggesting maneuvers, and I'm saying this will create inflammation. We do not want inflammation because it creates membranes, it creates problems with pressure, it creates all sorts of issues. So very valuable comments, and I'm always trying to find out, how can I do something with less invasiveness? How can I be smaller, quicker, lighter, etc.? So thank you very much for your comment.
There's another question from our colleague and friend, Dr. Nicola Ghazi. He has the mic now. You can
yeah, thank you, Adil. Thank you, Marco, for setting up this wonderful webinar. Dr. D'Amico, thank you very much. I enjoyed the talk so much. The videos, again, I echo my colleagues, were great, very tough cases. My question is related to the rather more frequent complication, which is the retroprosthesis membrane. I noticed that it looks like that the membrane is limited to the retroprosthesis area. And the fact that the hypotony rate is much lower than the retroprosthesis membrane, and from your surgical videos, it tells me that probably this is isolated from attachment to the ciliary body. So there is no cyclitic membranes, except maybe in the cases of hypotony without choroidals. So does the dissection that you perform, is it mainly limited to the retroprosthesis space? Do you go further out to the cyclitic, to the area?
This is a very sophisticated question, and it relates to what we were just discussing with Dr. Vargas. The latest theory on the membrane is that cells migrate from the surface down along the stem, out across the backplate and onto the K-pro, that this may be a surface phenomenon. When we do the membrane removal, we will often find that it extends beyond the device onto the near area, whatever it is, whether it's residual, capsule or posterior iris, etc. It extends beyond it. We will try with forceps to remove it, but we know biologically we are leaving some. But you're quite correct. We do not see it, the RPM part of the membrane, go onto the ciliary body. And once it does, if that's the cause of hypotony, I don't think it's something that we're going to be able to solve with surgery. I've wanted to do an anti-metabolite trial. I've tried work with steroid. It actually seems to help some. The problem is that if you use gas just doesn't work great in K-pro eyes. I don't know why. Every time I think I have a success, something happens. But if you put oil in a K-pro eye, once the oil is up against the device, you will have a retro K-pro membrane for sure, unless you suppress with very heavy steroid. So I think this is an area of biology where we need your help, where we need everyone's help to try to understand it. Klaus has talked about coating the device with some kind of biofilm that would have an anti-metabolite in the back of it. Remember all the work that was done with laser ridges for years ago with IOLs? We need innovation here, but a wonderful question. Thank you so much, Dr. Ghazi, for your question.
Thank you very much.
You're muted, Marco.
Yeah, I think you are ending the webinar. We know that you have also other commitments and it's about time. So we want to give you time to prepare for your next meeting. I would like to thank you very much again for this beautiful presentation. It was very interesting for us also because we started already some years ago with anterior segment to perform this type of surgery. So really, thank you very much for your time. We really appreciate it, and we hope to have you visiting K-Cash in person. Really,
for sure. I promise I will do it. I would love to. Thank you, everyone. Thank you very much. Thank you again.
Bye bye.